back to The Rest Isn't Orthopaedics. And today we are very excited. We have a third guest on, which is Professor Matt Costa from Oxford. He's a professor of orthopaedic trauma surgery at John Radcliffe Hospital. He is also the past president of the Global Fragility Fracture Network and a chief investigator of many RCTs. And I'll hand over to Matt just to say a quick hello.
Well, thank you very much to you and Anthony for inviting me, Rayhan. It's a great pleasure. It's an honour to be invited onto the podcast.
So we designed the first series of The Rest is Orthopaedics as a textbook of non-surgical care, trying to explain the non-surgical aspects, because we believe that they're the bits that really make the difference. But we thought we ought to talk a bit about surgery, and in our next podcast we'll talk about anaesthesia, because anybody on the ward, anybody in the MDT needs to be able to explain all of this to the patients and to their family. So I think a surgeon's view of all of this would be really helpful. But before we tackle the questions of what operations people need for what sort of fractures, I thought I'd like to bang on a bit about my distress at my patients being called NOFs, my patients being referred to as a neck of femur fracture. And I over the years, I've listened to lots of junior doctors being taught about hip fracture, and there's an enormous amount of complicated verbiage brought in, difficult nomenclature that I don't understand, and that the doctors often don't seem to understand, and the patients certainly don't understand. And I'm distressed at patients who leave hospital having been called or told they've had a neck of femur, who don't really know that they've had a broken hip. Nobody's spoken to them in English. So I thought I'd have a quick run at the anatomy of hip fracture for a general audience of non-surgeons like myself, and then you can take me to pieces. But if Grace, our patient, falls over in her 50s, she tends to get her arm out to try and cushion the blow, and she tends to break her wrist, possibly her humerus. Once she gets to her age, she's in her 80s, actually her reaction times tend to be slower, and it's often the hip that hits the ground first. It's the knobbly trochanter part of the hip that's sticking out that hits the ground first, and that can crack and break, and it can break into two pieces or more pieces. The way in which that crack goes across the bone will determine whether people want to screw the two pieces together or put a nail down the inside of the thigh bone. If that bit doesn't break, then the slimmest bit of the thigh bone is the neck of femur inside the hip joint, and that bit is the commonest bit to actually break. So inside the hip capsule, an intracapsular hip fracture. The problem with that breaking is that the blood supply to the head, the ball of the top of the femur, is inside that piece of bone, and it tends to get broken as well. So while you might be able to screw the two pieces together if you're lucky, in most people the head of the femur, the ball, is going to die, and it ought to be replaced with either a partial hip replacement of just that bit, or actually the whole of the hip joint with an artificial socket as well. And that's my view of it all. And a neck of femur fracture is therefore only one group of patients within the overall picture of hip fracture. But I'm sure there's technical reasons why it needs to be made much more complicated than that, Matt.
Well, it will disappoint you to know, Anthony, that I couldn't agree with you more. And in fact, there's no reason to know any more than that for patients or for doctors, nurses, therapists looking after the patients, really. Orthopaedic surgeons, for reasons that are not entirely clear to me, like to discuss classifications and particular bits of anatomy in great detail, and often confuse not just the listeners but themselves with these classifications. And we now know that the observer reliability of all these subgroups of different fracture patterns are so poorly, there's such poor agreement that are probably not worth using. So basically you've hit the nail on the head. The essence of this is really, as you described, a bit of basic functional anatomy. And anatomists and surgeons, particularly orthopaedic surgeons, love a bit of anatomy, and torturing people like Rayhan early in their training with lessons on anatomy and questioning which blood vessel goes where. And most of the time it's a exercise in, I don't know, it's an academic exercise rather than a real one. There are very few areas where actually the anatomy makes a huge amount of difference to what we do. The general rule for an orthopaedic surgeon is get to the bone, stick to the bone, and don't cut the long stringy things on the way in and out. And that's something I try and stick to most of the time when I'm operating. But the hip is one area where a little bit of functional anatomy actually changes what we do. And you said it, Anthony, it's that difference between a fracture inside the capsule of the hip joint, where the blood supply is likely to be damaged, and a fracture outside, where the blood supply is maintained. And if the blood supply is damaged, the bone won't heal. So we generally replace that bit of the bone. And if the blood supply is intact, there's a very good chance if we can hold the bone in the right place, it will heal. And therefore we fix that bone. And how we replace them and how we fix them is something that surgeons will spend hours debating. We actually rarely, in orthopedic terms, have the answer to most of those questions now. There's few unanswered questions, to my mind, about which intervention we do. But certainly, for most people looking after patients with hip fractures, and most importantly for the patients themselves, the only really important distinction is the break inside the capsule, in which case we're likely to replace your joint, or is the break outside, in which case we're likely to fix the bone back in place and hope it heals.
And to really take it back to basics, when Grace comes into the hospital, why is it so important that she has surgery, Matt?
Yeah, no, absolutely. You're absolutely right, Ray, and that's probably the most important bit. I mean, for me, there are two reasons. One of them is not because I like operating. I do, but that isn't the reason. The main one initially, and this is really important from the patient's point of view, is pain relief, because we could talk a day about analgesia and nerve blocks and so on, but the best pain relief for a hip fracture is actually fixing or replacing the broken bit of the bone. My mother-in-law fell off a push bike actually in her late 50s and broke a hip, and told me it was the worst pain she'd ever had, much worse than childbirth. I had no particular use for the second reference, but I understand that's pretty bad. So being worse than that seemed to be pretty horrific. And actually the relief you see in people after the surgery, just by being able to move their leg in the bed without those two bits of bone grating together is something that it's a great reward for surgeons and for patients, I think a big step forward. So pain relief is probably the most important immediate thing. And then the other major component, the other reason for fixing the bones is, of course, to allow the rest of the team to do their job in terms of getting that patient back on their feet and getting them home and getting them on with their lives. So it's about mobilization after the surgery. It facilitates full, unrestricted weight-bearing mobilization on the day of, ideally, or the day after surgery. So that's what the surgery is for, and that's what the patient really wants to know.
I guess that pain relief really helping them get back on their feet, which makes a lot of sense, of course. And then talking about, I know we talked a bit about intracapsular fractures and extracapsular fractures. How would we really differentiate as to how we would treat the patient?
Sure. Well, the first really serious attempt to try and determine which types of operation should be given to which patients was done by the NICE group in 2011. There was a lot written before that, so I'm not saying that history started in 2011 with the first NICE hip fracture guidelines, and I know Anthony was heavily involved, but that's where really the people started to think about how we join the service up. And the biggest part for me of 2011 guidelines was about multidisciplinary team working. So it actually wasn't about the surgery, it was about the whole team, geriatricians, anaesthetists, surgeons, therapists, nurses, bone health specialists all working together. That's really what that guideline was about for me. But inevitably, because surgeons were involved, there was some guidance related to the actual operation. And the gist of it was really related to that anatomy. It was basically, if you had a displaced intracapsular fracture of the hip, you should offer the patient an arthroplasty. And if you had a fracture outside of the hip, you should offer them a fixation of some sort. And the debates that was pretty clear. It was pretty clear in the guideline that's what we should do in for the great majority of fractures in those two basic subgroups. The nuance came in about which operations should be offered to which groups of patients, which subgroup of or subtype of joint replacement should be offered to the intracapsular fractures. So from after 2011, there were several large, sort of what we call pivotal randomized trials, the ones that really changed clinical practice, that helped to really decide what type of replacement patient should get after their hip fracture. And this is for the intracapsular fractures of the hip. So The first big question was whether we replaced just the broken ball at the top of the bone, so a half hip replacement, or whether we also replaced the socket of the hip, so give the patient a total hip replacement. And in 2011, I suggested that patients with higher levels of pre-injury function and mobilization should be offered a total hip replacement. The difficulty with a total hip replacement is it's a more complicated operation, and the risks, particularly the risk of dislocation of the hip, are higher, so the complication profile is different. But in 2011, we thought that actually most patients who are independently mobile outside their own home would benefit from a total hip replacement because they'd have better function afterwards than a hemiarthroplasty. So the key piece in the jigsaw that really changed our thinking there was a study called Health, which was a trial led from Canada, recruited in several countries actually, but including the UK, but led from Canada. And contrary to what we believed up to that point, it suggested that the functional benefits to patients of a total hip replacement over a hemiarthroplasty were very limited. So actually, there was a little benefit to be gained by having a bigger, more complex operation, unless you were really super high level of functioning, so playing sports and things before your injury. And that really changed how we thought about the treatment of intracapsular fractures. So we're basically now doing a hemiarthroplasty as the default, a half hip replacement from the patient's point of view, and leaving a total hip replacement to the very highest functioning sort of patients. And that the advice in NICE hasn't really kept up with that change in philosophy, I don't think, certainly for the UK. The second pivotal bit of information was if we're going to do a hemiarthroplasty for the great majority of patients with a hip fracture, what sort of hemiarthroplasty should we do? And the two big options were a cemented hip hemiarthroplasty, which is where the cement doesn't actually touch the bone. The implant doesn't touch the bone. It's surrounded by a grout, like the sort of thing you use to put your wall tiles on in your bathroom, that spreads the load on the femur, and that's called bone cement. And the alternative option was an implant that had a special surface coating that actually did touch the bone, and this surface coating encouraged the bone to grow into and grip the implant to make it secure. And in the context of a broken hip fracture, a trial called White 5, I'm a bit biased about this because I was heavily involved, suggested quite clearly that not only was the bone cement better in terms of the patient's function, it was also cheaper for the NHS and resulted in fewer complications than the uncemented. So after that study, we now know that most patients with an intracapsular fracture can be treated with just a half hip replacement, a hemiarthroplasty, and that half hip replacement should be cemented rather than uncemented. So that's where we got to with arthroplasty, and that's what happens now in the great majority of patients with an intracapsular fracture in the UK. Exactly which type of implant you cement, what the manufacturer is probably less relevant than just doing the cemented implant. The question that's unanswered for the intracapsular fractures is what about the fractures that are completely undisplaced, the ones where there's a crack but it's not moved anywhere, where the blood supply is probably intact. And for those fractures, that's where the latest trial evidence will report, hopefully in the next couple of years, a study called White 11 Fruity, which is comparing fixation versus replacement for that very specific subgroup. But that's only about 5% of hip fractures, so a bit of a niche question.
Okay, and then so I know we mentioned intracapsular fractures and talked about those, and then extracapsular fractures where the blood supply is a bit more maintained. How does that really differ?
So now we're trying to fix the bone. And many of us, I think, would argue that what piece of metal you use to fix the bone is less important than how you use it. So fixing the bone in the right place, getting the screw into the head of the femur in the right position, and making sure it's securely attached to the shaft is more important than exactly which device you use to do that. So the technicalities of the surgery, which is kind of what we all get paid for, that's more important almost certainly more important than the actual type of metal you use. The big distinction between the types of metal is between so there's always a screw that goes into the head of the femur. The distinction is how you attach that screw to the shaft of the femur below the fracture. And the two options really are a plate, which is on the surface of the bone, or a metal rod, a nail it's called, that goes down the center of the bone. So an intramedullary nail versus a sliding hip screw, and they're the two big types of devices we use. And there's a Cochrane review, very recent one, 2022 update, which reports that there are now over 100 randomized controlled trials comparing sliding hip screws with nail fixations for extracapsular fractures of the hip. And despite the arguments that still go on in orthopaedic meetings, there is no difference in the functional outcome for patients. You can pick and choose which intervention you use. In the UK, sliding hip screw is most commonly used because it's cheaper and arguably because it's just as reliable. Unarguably because it's just as reliable. Whereas for reasons not entirely clear to me, a lot to do, I think, with training and marketing, then nails are more common in Europe and in North America. You can choose which device you use, but in terms of cost effectiveness, the sliding hip screw is better for the majority of fractures. Okay. The outstanding question in that area, the one group of patients, subgroup we don't know about, and this is a small group, around 5%, are the patients with really unstable fractures, extracapsular fractures, where the lateral wall of the femur is broken through, and there's some evidence to say they don't do as well with a sliding hip screw. But that's really the only area where we don't have strong evidence to guide which type of implant we should use for extracapsular fractures.
Thanks. And then I forgot to mention one sort of hip fracture when I started, and the subtrochanteric fracture. So when Grace falls over and bangs her trochanter on the floor, the bit that doesn't get a direct impact is the bit of the thigh bone just below that, the subtrochanteric region. And that's an area where the fractures shouldn't really happen unless there's an intrinsic weakness in the bone there. So Rehan, pick on you, but causes of intrinsic bone weakness. What sort of things might lead to a hole in the bone that breaks if somebody has a tumble?
These are always my least favourite parts of the podcast. But I guess a cancer, so a myeloma, but then a metastasis from somewhere else potentially as well.
So you're going to have to give me a list of 4 diseases that Grace might have.
So I remember someone told me that they start with B. So there's the bronchus, the breasts. I think you can kind of work the thyroid, the thyroid and prostate, and then I can't remember the last one.
Kidney as well.
Kidney, okay.
The kidneys are a particularly exciting one because they tend to be very bloody. If you're operating on those can be quite challenging. So you want to spot that's where the mets come from for before you do your operation for those. And then of course I and my colleagues dishing out anti-resorptive therapies, in particular repeatedly dosing people with oral bisphosphonates or repeatedly giving bisphosphonates for patients with cancer can lead to a breakdown in the metabolism of the bone and the intrinsic repair mechanisms of bone, so that you get something called an atypical fracture related to bisphosphonate use. And that's a particularly challenging extra orthopaedic issue that we probably don't need to take much further forward. But Matt, subtrochanteric fractures, what do you do for them?
So the big thing is what you and Rehan have already mentioned, is that these are often there's something else going on. This is not just bad luck and a fall. There's a weakness in the bone there, whether it's due to metabolic bone disease and bone health medications, or whether it's due to metastasis or some other underlying condition. So spotting those and treating the patient for that condition is just as important as the surgery side. From the surgery side, a subtrochanteric fracture, although it was lumped together with the rest of the hip fractures, it is really a fracture of the shaft of the femur. It's the below the hip joint, essentially. So the treatment is essentially the same as any shaft of the femur fracture, which is a nail. So there's evidence from trials now that the nails do better for subtrochanteric fractures than an extramedullary device, a plate on the surface of the bone. So we treat them in the same way we would do a shaft of femur fracture, or even a distal femur fracture with a metal rod on the inside. And the National Hip Fracture Database obviously has changed to incorporate femoral fractures now, which makes a lot of sense to me, because only including the very top femoral shaft fractures didn't make much sense to me at all. So yes, you're absolutely right. They're included in the hip fracture nomenclature, but they're really a type of fracture of the shaft of the femur just near the top. And we generally treat those with a nail. If surgeons are going to earn their money here, it's with those atypical fractures, because often they have a deformity with them. And actually correcting the biomechanics is really, really important for those fractures if they're ever going to heal. So that's where your orthopaedic surgeon should be earning their money, by spotting that deformity and trying intraoperatively to correct that. So you can't cure metabolic bone disease with a titanium rod, but you can change the mechanics of the hip and give it a chance of healing. So that's if I get paid, that's what I'm paid for, really, that sort of thing.
Thank you.
Yeah, well, thank you very much, Matt. That was really cool, and I really enjoyed it. It was really interesting to hear a surgeon's opinion, like the main thing that gets Grace back on her feet and walking again. So thank you very much for speaking to us today, and we hope it was useful for everyone, especially all the medics who don't actually really know much about anatomy like me or Prof, I'm sure. But yeah, we've got a similar episode for anesthesia coming out soon, and we hope you tune into that. We hope you enjoyed this one, and see you guys soon.